cases.
Again, just, working to innovate to bring better results with the combination, the stacking of the therapies. What about a patient? We were communicating about a patient earlier today where they had a lumpectomy and, had 2 lymph nodes removed, sentinel, they were negative. And, the conventional recommendation that she was receiving was radiation. And she was adamant. She was not going to get radiation.
Right. Yeah.
So is there maybe the future where could you cryo that bed?
Yeah.
Is that something that's possible? I mean, or is that a better choice of cryo versus PEF? What?
Yeah. The problem is that, in there, you're going to be killing a lot of like healthy tissue and stuff. So it's going to be really unpredictable what you're going to achieve with that.
Okay.
So yeah, I don't know. I don't know if that would be a great option. I mean, the better option would to never be to even do the lumpectomy in the first place. It would be to go directly to like ablative technology combined with immunotherapy and treat with that and avoid surgeries. That's going to be the future. I know we're not there yet, but I think once we can get the data and prove it, we'll start showing that you don't mess around with the tumors. You just go in there, I mean, again, the future of cancer treatment is this. There's a suspicious lesion. Don't biopsy it yet. We know it's suspicious. We think this is cancer. Let's go ahead. Let's plan. We're going to treat it. We'll sample it while we treat it, but at the same time, we're treating it. We're not going to sample and then, okay, go away. A couple weeks later, oh yeah, now you got cancer. Oh, now we just made it mad. So now, okay, now we got a real problem because this is what happens now, right? So, but this is not the way things should be. It should be the patient, you say, okay, yeah, this is most likely cancer. Let's go ahead. We're going to start treating it. We're going to prove it. Okay, yeah, it's cancer. Look, but we treated it. And then now let's watch and see what happens. But we've already started the treatment process right from the biopsy, right from the start, not to wait till later. I mean, we should start that then.
Yeah, because if you do a core biopsy on a breast mass, for example, you poke the bear and then you just let it fester, right, for weeks.
Yes.
And these days it seems like months. Weeks to months.
It can be a long time.
Yeah, it just festers. Versus what you're saying is you go in, you poke the bear, and you treat it, you're done.
Yeah, and the thing is that there's realistic situations. You can look at those scans and tell a person, oh yeah, that's probably benign, right? I mean, that's probably fibroadenoma. I mean, that type of stuff. Oh, this is probably a cancer. But when you're in a situation where you're dealing with something that this is more highly likely a cancer, then you should be treating it as such. And until proven otherwise. I mean, maybe biopsy and it comes back as not a cancer. That would be great. But, I think that the way that they're approaching with these women, just biopsying all these things, and I don't know. It's not. I don't think it's the right way to go about it. I mean, I think that they should do this differently with the patients. And yeah, I mean, you could certainly. I mean, like, I can tell you, a lot of times, like, you follow a protocol. Okay, patients, certain age, palpable lump, you're supposed to biopsy it. You look at it and you're like, oh, that's a fibroadenoma. I mean, look, we can make most of the decisions on this on imaging. Yeah. I mean, we should be in the high 90-something% with imaging, knowing that that's cancer up front. So that when we say, okay, this is cancer, let's go ahead and treat. Let's not just biopsy and say, oh yeah, let's hope it's not cancer. We know it is, right? We're going to biopsy and say, yeah, we're going to biopsy and maybe there's chances not. But what we're really telling you is that we're going to biopsy it and your chance is probably 1 or 2% that it's not cancer. I mean, that's not a good odds.
Because what we're trying to do here is harness the power of the immune system, not locally, but again, systemically, what's called the Abis Scopal effect. So what about, because the Abis Scopal effect, that that term and that definition, it really was kind of born out of radiation, wasn't it?
Yeah, I think probably so. Just the distant effect and yeah, it's been seen previously and described many different times, and obviously for us, we started seeing it with ablation in early 2000s. Other people seen it in some ablation type techniques even done in the 60s and 70s. I mean,
Wow.
There were a couple of cases where they were using liquid nitrogen, I think, on prostates in the 60s, and saw resolution of bone metastasis. There's a published article like 1967, and yeah, and but they're like nothing to see here, right?
Yeah. Hot down under, cold down. Tell you what.
Yeah.
Oh my goodness.
Yeah. It's funny how they'll come along these things, and you would think that they would say, "Oh yeah, it's like we should really look at this," but then they kind of let it go, and then things go a different direction.
Makes you wonder, huh?
Yeah.
But when you look at radiation, because radiation, it doesn't really create a great episcopal effect.
Yeah.
And so it's described very repeatedly in the literature about variable, and it's weak in terms of the immunologic effect, the episcopal effect distally. And whereas the pulse electric field therapy is really providing a profound effect. And I guess, is it because radiation is just going in there and just ablating all the antigens, the immune system, everything?
So radiation, you can definitely modify it. You can modify dosing. Like, it's actually lower dosing is more immune stimulating than higher dose. Timing of the radiation is actually very important. So a lot of it depends on where the person is in their immune cycle. There's an immune cycle in patients where the immune system attacks cancer or doesn't attack cancer. Depending on where you, when you radiate, you may get an immune response or you may not. Right? So there's lots of variables that go on with it, and so that's a challenge of radiation. Obviously,
can you touch on that immune cycle real quick, because
yeah,
that caught my attention. I'm sure it caught the attention of the listeners.
Yeah. This reason was described by a guy named Martin Ashdown. He's from Melbourne, Australia. I talked directly with him because he contacted me and said, he's like, hey, it's interesting your work. And what he had shown was they were looking at particularly things like interleukin-2. So what do you see, like when patients with renal cell interleukin-2, you occasionally saw these like home runs.
Yeah.
And then you saw these like where the patients just got worse and there was no explanation. But what Ashdown looked at was that he said, okay, the immune system sometimes may want to attack cancer, and so sometimes it's like attacking, and sometimes its phase is more toward the regulatory, protecting. And the interleukin-2 is, going to boost whichever one is. So depending on the luck of when you give it. So it's like, okay, there's a war going on. There's two sides. I mean, you're going to throw your guns to the people, but what's your timing? If your timing's off, you throw it to the wrong group, right? you armed your enemy, right? So that's
interception.
Yeah. So that's kind of what happens with that. Like if you give interleukin-2 when the immune system is going more regulatory, you boosted that regulatory. Now you actually increase your protection for the cancer. Or when the immune system is wanting to attack cancer, then you boost it to attack cancer. And that's what sometimes it works and sometimes it doesn't. So if you timed it, and I know that they actually did some further studies, and he sent me some things where they did some stuff with the radiation, and they were like timing the radiation with the immune cycle, and they were getting some pretty decent responses where, I mean, they could boost it. Obviously that's complicated, to do, and nobody wants to do it. I mean, we years back when we didn't, now obviously we have better techniques, but before we had things like pulse field, and before that we we worked with our radiation oncologists with this idea of like actually timing and doing these things. So,
oh, wow. So you can actually, at least some way, try to measure where somebody is in that.
yeah. So so Ashdown, when he told me, he describes the immune cycle as like a menstrual cycle, and so and he says it averages about 8 days for most people, and he found that he could measure it by looking at high sensitivity CRP.
Interesting.
And so you take the patients, you measure CRP, and you would see it would go up, and then it would peak. That would be like your middle part, like your day 4, and then it would come down, and then that path would be your cycle, and then you could try to figure out when they were on the regulatory, when they were on the effector, and then you could predict their future, so that you would know where they're at, right? Right. So you could pick up that person's immune cycle, know where they're at, and then step into it and treat on that. So yeah, we used to do this stuff. We were measuring high sensitive CRP and like checking all these type of things. It was really challenging. Thankfully now we've gotten so good with the agents that we're sort of like kind of bypass that a little bit, because it gets a little complicated to do, and so we're able to not, we're able to do things that will. Well, of course, like we're doing a lot of stuff that the medicines are lingering, in the area, because like we're putting them like in gel type stuff and all that, staying in the tumor, so they're different than the overall. This is a lot, particularly when you're talking about like a systemic response. The immune cycle is probably much more important. When you're talking locally, this is probably different.
Yeah, and that's you brought up a good point. There is that a lot of people go, well, I'm getting systemic Keytruda, or I'm getting systemic Yervoy. It's like, well, how is this different, and how is it not going to leak out of the tumor and give me the potential same side effects that I got from the systemic therapy?
Yeah, and and we've analyzed this a little bit now. We have some data where we inject into the tumors, and we measure the patient's blood at all different hours, looking to see how much. And some patients, the drug was undetectable in the blood. Some patients it was a little bit detectable. Oddly enough, the responses were, in our prostate cancer trial, were greater in some patients where it was detectable in the blood, which was strange. You would think that wouldn't be the case. Mm-hmm. But yeah, I mean, again, you want to keep most of it in that area and most of it in that draining nodes. I mean, you don't want it off going areas where there's no cancer. That doesn't help you.
Yeah, because you get that kind of off target toxicity, and then that potential bystander effect where it damages healthy cells, and that potentially could trigger senescent cells, and then a whole chronic inflammatory process that's just a big mess.
Yeah, and also I mean, you're alerting the immune system in other places where there might not be problems, or so you're sort of like crying wolf. Hey, the immune system's like, hey, okay, what's going on? Then like the immune system's like, hey, there's nothing going on. So the immune system's like, I'm not gonna listen to you anymore.
That's a good point, because people say, well, just kickstart the immune system, and it's like, well, the immune system actually, you can kickstart it too much, and the cancer can actually use some of that immune signaling. That's what, when you were talking about interleukin-2, that's a cytokine and immune signal. But I mean, if we get too much, so for example, TGF-beta, that's something I talk a lot about. Too much TGF-beta, transforming growth factor beta, can actually be a means for cancer to spread.
Yeah.
And so you have to control them.
Well, certainly cancer does not live without the assistance of the immune system, and even other cells. I mean, so, cancer, when it's, a lot of times people think, oh, you need to kill a cancer and the rest of your body's against it. No, the rest of the body's not against it. The rest of the body's actually helping the cancer. So you're fighting against your own body. I mean, you think like, oh, it's like people, that's why a lot of times they would look at like metabolism and other stuff. That's not going to fully get it on these things. I mean, the cancer is getting assistance from other normal cells.
And what I tell people, Jason, is cancer doesn't create anything new. It just adulterates what's there for its benefit.
Yeah, I mean, if cancer was doing something beneficial, it would be an organ.
Yeah.
But it's not. It has a mutation and it has this. It's gotten rogue and its own own agenda. It's just corrupted, right? It's not and but it wants to survive, and it does what it's going to do to try to survive.
Yeah, it's kind of a life form, so to speak. I wanted to kind of wrap up this talking about PEF. We're doing some deep dives on PEF plus immunotherapy and comparing that to radiation plus immunotherapy.
Yeah.
I came across some interesting quotes from some articles and love to get your thoughts on it. First was from a British Medical Journal that PEF combined with checkpoint inhibitors has shown significantly prolonged survival in preclinical models. Of course, it's preclinical, but especially in tumors that are typically resistant to immunotherapy alone. And so here, they're showing that patients that have shown resistance to immunotherapy, PEF, of course, preclinical, it actually allows the immunotherapy to almost be resensitized and activated to the tumor.
That's right. Yeah. Yeah. I mean, that's why, when you have patients who've been given immunotherapy and say, oh, immunotherapy didn't work. Gosh, I mean, if they have a chance to get PEF, I mean, if you get PEF, maybe they turn it around.
Yeah. So if you're a patient out there and you're listening, you go, well, I've tried, Yervoy, Opdivo, take your checkpoint inhibitor, and it didn't work. Well, number one, it could be simply the systemic to tumor approach. That in and of itself could be the issue. And it could be that, what Dr. Williams has innovated in taking basically the approach right to the tumor, that could help to solve the issue. But here, it could be simply adding the ablation, whereas the tumor was resistant to the immunotherapy, the ablation itself activated the ability to respond to the immunotherapy. So I think that really opens up the doorway to a lot of different therapeutic benefits of PEF. And then looking at radiation plus immunotherapy, looking at the immune activation being much more localized, less potent, and as a result, what they said, less predictable and weaker immune activation compared to PEF. Another British Medical Journal. So they actually were saying, look, radiation compared to PEF, the PEF was creating a more predictable, sustainable immunotherapeutic response.
Yeah.
Which is crazy. Why not seeing it more applied in oncology?
Yeah, I know. I mean, I think that PEF, has great potential. It's just coming out. Hopefully we'll see it used a lot more. I mean, it really should be everybody with an advanced cancer should have the opportunity to get PEF.
Great, and because it's just energy. And then this last one, looking at PEF plus immunotherapy, PEF, this is a quote, when combined with immunotherapy and chemotherapy, here particularly looking at cisplatin, it significantly improves survival outcomes in aggressive tumor models, preclinical. The combination therapy is particularly effective in cold immune tumors that are otherwise non-responsive to immunotherapy. So in closing, some tumors just don't seem to respond to any type of immunotherapy at all, and they're referred to as cold. Versus others like melanoma, which is like a hot tumor, it tends to be very responsive right out of the gate. And here, what they're saying is these non-immunologic responsive tumors, PEF can really pop them and activate them.
That's right. Yeah, I mean, it's like you're shocking in there, and you might alert the immune system to come and attack it and change a cold environment to now a hot environment, and now these immunotherapy drugs that wouldn't work before could work. And so it's a major tool that really needs to be used a lot more, and hopefully we'll see it. I mean, I know we got the guys at Galvanize, and I think they're trying obviously to push this a lot more in cancer, and the big driver on these is always financial. And financially, PEF does not pay very well. It is not financially actually even feasible for somebody to do. The payment on it is actually less than the cost to do the procedure. The needle costs more than insurance pays you to do it. So that is hampering it, right? Because like until insurance changes that and pays something better, doctors are not going to do it. Because like how do you commit? I mean, I would love to send plenty of patients for PEF, but I usually get it for as favors, right? Because like I say, hey, will you do PEF? Yeah, do it, but they don't want to do it because, and the hospitals eventually will start getting onto it. Look, I went through this with ablation before, where we were doing lots of ablations, and then eventually the hospital was like, hey, we're not making money on this.
Yeah.
And so you better stop. And so, for us, like a lot of times as doctors, particularly like when I was in university, I mean, look, you're on a salary. You don't, whether you do 1 case or 100 cases, doesn't matter. You're just looking to do cool stuff. And so for me, I was just trying to do more stuff. I didn't know if the university get paid or not. It didn't really matter to me. So
no patience.
Yeah, I just was doing what I was doing. And so, obviously the money complicates things and messes this up. And, you look at cardiac cath and stenting. I mean, originally in the 60s when the radiologists first, developed cardiac catheterization and stenting, nobody was doing it. Nobody was doing it because insurance wasn't paying for it. But when insurance eventually decided in the mid to late 80s to pay for it, then all of a sudden it became a procedure, and then the cardiologists jumped on it and took it over and started doing it. But the procedures go where the money is, and you see a lot of stuff being done that's not useful, but if it pays well, they do a lot of it. Y90, not that great. Pays well. They do a lot of it. So
the finance side of things, the insurance reimbursement side of things is disincentivizing.
Yeah, it is.
In an innovation of energy to ablate a tumor and activate the immune system to do its job.
Yeah. So, I think that it'll have to be where the PEF companies like Galvanize hopefully will get enough enough stuff, enough power to be able to try to lobby and change that and get better payments. And I think, once PEF gets paid to a level that would make sense for it, then that'll change.
Or if you're a patient, you can be the force multiplier and get more patients involved to be that vector of change.
Yeah, it is. It's hard to say with patients because obviously it's challenging, but yeah, I mean, I guess also they can also try to go, write their politicians and stuff. I don't know. I don't know what it takes to do it.
Oh boy, good. Well, Dr. Williams, Jason, it's great to talk to you. Fantastic discussion on PEF. So now when people are having questions about PEF, they can be directed right to this podcast and be able to hear the world expert on PEF and intratumoral immunotherapy, Dr. Jason Williams, give you direct answers to your questions and be able to pass those on to other people that have questions. Thank you for joining us, Dr. Williams.
Yeah, thank you, Dr. Goodyear. Appreciate it.